Well, a warm welcome to today's update. It's Monday the 14th of June. Some news from around the world today, but of course thinking about the UK, as we anticipated today, the move from stage 3 to stage 4 of the release from lockdown in the UK has been suspended up until the 19th of July, which we expected for some time. Actually, at least for the last sort of week or so, we've been anticipating this. So no big surprises there, really. More information on the rationale for that in a minute. Just before we do that, here's the graphs at the moment. So here we see the line for the United States. Now, we've looked at this in detail recently, but at the moment, this is our world in data. That is looking flattish there for the United States in terms of cases. Canada, we still see a reduction. They're still going down, which is good. Ireland going down to flattish, and the UK, well, no prizes there for who's doing worst of the English-speaking countries at the moment. So, as we've said, 19th of July is now the time. That will give us time to bash in another 10 million vaccine doses, which of course is good. Now, this is largely due to the Delta variant. Now, we've known for some time, and this applies to the UK, but it applies everywhere, really. We've been looking at these 4 tests that the UK government's using to adjudicate when it's time to relax restrictions, and we've looked at these a few times. But let's look at the graphics from today's briefing, which are really quite informative and quite useful. And so here we see them here. Now, these are related to the roadmap test. So test 1, vaccine deployment programme continues successfully. So here we have the first doses. Here we have the second doses. We see increasing number of people with the second dose. 41.7 million individuals have received one dose. Of these, 30 million have received a second dose. So that is going well. So the first test is clearly met. The test 2, evidence shows that vaccines are sufficiently effective in reducing hospitalisations and deaths in those vaccinated. Now, this first slide to answer this one is protection against symptomatic disease of the Delta variant, first identified in India after 1 and 2 doses of the vaccine. So we see there's a 26 to 40% reduction after 1 dose, not too brilliant. Now, they just call this the vaccine. They don't differentiate between the 2 doses, between the Pfizer and the Oxford AstraZeneca. Most of this data actually comes from the Pfizer. And that is because the Pfizer vaccine, we've been collecting data on it for longer. Now, Pfizer vaccine generally, as a general principle, that the immunity builds up quicker than the Oxford AstraZeneca, but the Oxford AstraZeneca, it carries on building up for a period of time. But of course, data is still being collected on that. So we're having to wait at least 2 weeks after the second dose of the vaccine to get these most beneficial effects. So two doses of the vaccines, what they're saying here is 76 to 84% reduction in symptomatic cases. So it's not as good a level of protection as we're getting with the B.1.1.7. It's not as good a level of protection as we're getting with the wild variant, of course, but it's still better than it could have been. Estimated reduction in hospitalisations from the Delta variant. So 1 dose of vaccine, 57 to 85 reduction in hospitalisations, 85 to 98% reductions in hospitalisations after 2 weeks after 2 doses. And it's still true that the people that are being hospitalised are those with more comorbidities and frailer generally, but not everyone. Some relatively young, relatively fit people are still being hospitalised, but thankfully just in much smaller numbers. Evidence shows the vaccines are sufficiently effective in reducing hospitalisations and deaths. So this is age distribution of hospital admissions in the UK. Now, this is 1st to the 28th of January, before the vaccine programme had kicked in very big time. So under 65s and over 65s. So hospitalisations mostly in over 65s, hospitalisations less in under 65s. Now, because the over 65s are nearly all protected with 2 doses of vaccine, under 65s are the larger percentage of people in hospital. And of course, the overall numbers are down because this age group is hospitalised less, whereas the over 65 being protected by 2 doses of vaccine, the admissions are much less. But we note they are not 0. So this link between vaccination cases and vaccination, there's less cases after vaccination and less people getting sick. So even although there's still cases, the link between hospitalizations and death has been greatly weakened by the vaccine, but not severed altogether. That's the main point of this. Moving on. Average number of weekly cases per 100,000 people in the northwest and England. So this is the northwest, where of course there was most cases of the Delta variant, and this was the rest of England. So 64 increase in cases since last week, and here, even though the numbers are much lower, still a 64% increase. So basically the rest of England is now following the northwest, and this increase in cases from down here. So this was the B117, the UK Kent variant. This was the India variant here, the Delta variant, and we see it's causing a 64% increase in cases. Now, to begin with, most of the cases are in the northwest. Now they're spreading all over England. So the new cases in the average number of weekly cases per 100,000 people went up first in the northwest, but unfortunately the rest of England is now following. And that shows the distribution around the country. So this area was the initial focus for the Delta variant, but now the brown is the worst, the green is the best. We see it's basically all over the country now. Unfortunately, we did say to stop the flights from India, but it didn't happen. Average number of weekly hospital admissions. And again, we see it's gone up in the northwest, 61%. And 50% in the rest of England. Now, these numbers are low, but if they're doubling every week or 10 days, then that's obviously exponential growth, and that is the risk. So we see the India variant here and the effects of the old UK Alpha variant here, and we see the effect, and the risk is, well, we do know that England is going to carry on going up with increasing cases because of that graph there and the distribution of the Delta variant. Number of sequence, genotype, Alpha and Delta variant cases in England over time. So here in the browny gold colour, we've got the Alpha variant, the original UK Kent variant, and just look at how quickly the India variant has taken over. It's now about 97% or something. But basically, the Delta variant, the India variant, has completely taken over the Alpha or the UK Kent variant. It's just replaced it because it's more transmissible. And this area in grey, the data is incomplete, and so these numbers will continue to grow, unfortunately. So I thought they were pretty useful graphics, really. Let's look at a bit more about the this Delta variant. Now, it seems to give a higher viral load for longer. So it's giving a higher viral load, that's making it more infectious. And because there's a higher viral load, people are also getting sicker. The current estimates are, there's a study out from Edinburgh University today, I'll give you the reference in a minute, but it's 84% more hospitalisations with the Delta variant, the India variant, than the Alpha Kent variant. So it is spreading much more rapidly, perhaps about 64% more rapidly, and about 84% more hospitalisations. This is a serious issue, and it's happening all over the world. Higher viral loads for longer. 74 countries was the last count that I did today. Most contagious variants so far. Spreading in China, Namibia, US, Scandinavia, Pacific, Mongolia, Brazil, Argentina, Chile, for example. Now, there's something really quite important to say here, and that is the change in presentation. Now, we have looked at this before, but I want to stress it. So people being infected at the moment, partly because there's vaccine around, partly because there's natural immunity around, partly because it's affecting younger people, but the presentation is changing. And it's so important to know about the presentation, because if you think you have it, you need to get tested. You get a lateral flow test. If that's positive, you get a PCR test to confirm it. Or even get a PCR test straight away if you suspect you have it. And of course, you isolate until you get a negative result. So change in presentations very often, especially in younger people, this is presenting much more like a common cold. So they think they've got a cold and don't realise they could actually be spreading the Delta variant to other people. So we have to have a high index of suspicion, and this is true wherever you are, because we'll see in a minute that even in the United States, the Delta variant is now 10% of cases. So you have to have a higher index of suspicion. So cold-like symptoms, and the symptoms since May, most common is headache, second most common is sore throat, third most common is runny nose, fourth most common is fever, fifth most common is cough, whereas of course that was the cardinal feature before, and loss of smell is less common. Now for most people, of course, this is going to be mild, it's going to go away, but they could spread it to someone who gets severe disease and could become ill, hospitalised, and even potentially die from this. So very important to realise this change in the presentation. Now it is, as I say, the Delta variant is probably going to become the most prevalent variant everywhere in the world. It's basically spreading because travelling's still going on. Now we'll be getting a report from Australia later. Hopefully Australia is going to get away with this, but Susan's left us a new report, but I haven't watched it yet, so I'm going to watch it with you, but more on that in a minute. So this place in China, Guangzhou, I can't pronounce it, 12% of patients becoming severely or critically ill within 3 to 4 days of symptom onset, according to the local health authorities. So whereas we were seeing about 5%, maybe 6% of people getting ill with the previous variant, that's kind of doubled. So Edinburgh University is saying about 84%, which isn't too far off double, to be quite honest. And in China, it seems twice as many people are being hospitalised who have been diagnosed 3 or 4 days after onset of symptoms with the Delta variant. Consistent reduced vaccine efficacy after one dose. So the Chinese vaccines aren't working very well after one dose, but they're working much better after 2 doses. So the pattern in China is much the same. 1 dose not giving much protection, 2 doses giving much better protection, but perhaps double the amount of people being hospitalised, unfortunately. So it's spreading in Indonesia. New wave of infections. The peak, according to the Indonesian authorities, is probably going to be July. Jakarta hospitals are 75% full already, but it's still going to go up for another month or so yet. Democratic Republic of Congo, Kinshasa, the capital hospitals are overwhelmed. The president has said, I'm going to take drastic measures to deal with this upsurge of the disease, although I'm not quite sure what measures he is taking. And we're talking about the India variant in particular, the Delta variant, exactly, direct quote from him. Zimbabwe, localised lockdowns. Delta variant is also in the United States, currently 10% of cases in the US. But of course, it's not long ago it was 10% of the cases in England. And if the US follows the English trajectory, or the UK trajectory, because the cases are high in Scotland, Wales and Northern Ireland as well, then it will start to displace the previous variants, exactly as we saw it has done in the UK, where the Delta variant is now way over 90% of cases. I saw a study from Scotland today. I think it was about 96-97% of cases in Scotland, so it's just taken over. Now this is data from the United States. Proportion is doubling every 2 weeks of that's the Delta variant there, of course, the B1617.2. Now it's the same point variant as is in the UK. That's the more transmissible one. Probably will become the dominant strain in the United States, I would say, over the next few weeks. This chap, Scott, no, can't pronounce his name. Sorry, not very terrible with names, aren't I? Anyway, Scott says he's a former commissioner at US Food and Drug Administration. I think he's working for Pfizer now. But he says this, I think in parts of the country where you have less vaccination, particularly in parts of the south where you have some cities where vaccination rates are low, there's a risk that you could see outbreaks with this new variant. So very patchy uptake of vaccine in the States, particularly the southern states, aren't doing so well. So where less than 50% of adults have had at least 1 dose, Alabama, Louisiana, Mississippi, Wyoming, less than 50% of adults have had 1 dose. So they're particularly behind. Now, what should we do now? I was going to give you a report on the new Novavax vaccine, which is looking very promising. But I think we'll go to Dr. Susan Oliver and her dog Julie in Australia, and we'll have the Australia update. And I'll find this interesting because I haven't seen it myself. So, Julie, as always, thank you very much for your updates. And let's watch that now.
Hello, this is Susan from Sydney with a COVID update from Australia. And it's mainly a good news update. So the outbreak that I mentioned in Melbourne in my last update now appears to be under control, but it did get worse before it got better. And the 1 week lockdown was extended to 2 weeks. That lockdown is now over, but there are still significant restrictions. And those restrictions include Melburnians not being able to travel more than 25 kilometres from home, mandatory mask wearing outside of home unless you're eating or drinking, and gyms and nightclubs remaining closed, and no visitors in the home. Now, for some reason, they've stopped reporting the total number of cases associated with the outbreak, but my counting puts it at 94. And that includes 2 people who decided to escape the lockdown in Melbourne and go on a road trip through regional New South Wales and then into Queensland. Needless to say, New South Wales and Queensland are very unimpressed. So far, there haven't been any positive cases in either state, which is great. But a lot of people are now in 14 days quarantine, and that's not so great. Now, I'm sure 94 cases probably sounds quite trivial to people who don't live in Australia, and you'd be wondering why we are even worrying about it. Here's the thing. Quite a number of those cases had already been identified as contacts of positive cases and were already in quarantine and therefore not spreading the virus to anyone else. So if we hadn't done extensive contact tracing and identified all these people before they tested positive, cases could be in the thousands by now. Most of the cases in Melbourne were what is now known as the Kappa variant, and we were able to genomically sequence them to each other. So we know they are all part of the one outbreak, which basically started from one person. But concerningly, one new cluster that emerged was the Delta variant. They were able to link the cluster genomically to someone in hotel quarantine, but it remains a mystery as to how it escaped. Luckily, as this cluster emerged while Melbourne was in lockdown, it doesn't appear to have spread too far. But it is yet another reminder that we have to assume that we have virus in the community and act accordingly and not be complacent. In particular, we need to do everything we can to protect vulnerable people. One thing that is being considered in Australia is making vaccination mandatory for aged care workers, and that's already the case in terms of flu vaccinations. Now, the mandatory vaccination in terms of COVID vaccination won't happen straight away because obviously you need to, give aged care workers ample opportunity to get vaccinated before restrictions can be imposed, but it is likely to happen in the future. In the current outbreak, the virus did get into an aged care home and 3 residents subsequently tested positive. But here's the good news. They had all been vaccinated with at least 1 dose, and although they tested positive, they remained asymptomatic, which is fantastic because in the last outbreak, the death rate amongst residents in aged care homes was 1 in 3. Now, onto vaccinations, which have had quite a surge. And we are now closing in on 6 million vaccinations. And that includes 60% of people over 70 and 40% of people over 50. And also people over 40 are now officially eligible to be vaccinated. Now, this does have some people over 50 a bit miffed. And the reason for this is that people over 50 are getting the AstraZeneca vaccine, which is being given at a 12-week interval because the clinical trial showed that this provided the greatest efficacy, whereas people under 50 are being given the Pfizer vaccine, which is being given at a 3 to 6 week interval. So this means people under 50 are going to be fully vaccinated before people over 50, even though people under 50 are obviously at lower risk. And I must admit, I'm a bit miffed too. I personally think they should extend the dosage interval to 12 weeks for everyone getting the Pfizer vaccine unless they are in a high-risk group and try to get more first doses for everyone. And the reason for this is because both vaccines provide very good protection against serious disease and death with 1 dose. But alas, I don't make the decisions. Now, I'd like to finish by addressing a very serious issue which appears to have emerged with vaccination, and that is the issue of vaccinated people becoming magnetised following vaccination. So I'm now 20 days past my first vaccination, so I should be quite magnetised by now. So let's check it out and see if I can get this spoon to stick to my forehead. Okay, let's hold it there. Oh, that didn't work at all. Maybe it's only magnets that stick. Okay, so here's a magnet. Let's see if I can get that to stick. Okay. Oh, no, that didn't work either. No. Now, I'm sure most of you aren't too surprised about my failed experiment, but the question is, why did the rumour start in the first place? I find usually these things start because someone has come across some scientific information and completely misunderstood what they were reading. So there's two possibilities here. The first is people have confused metal ions with metal. Now, I've lost, where's the spoon gone? Oh, here it is. A lot of people, this spoon is made out of metal, and this isn't something that you'd like in your body. But we do, in fact, have lots of metal ions in our body. So this spoon contains the iron, the metal, but of course, metal ions like iron are in fact essential to life. And another obvious one is, common table salt, which is actually sodium chloride. And sodium is a metal, but when it's ionized, it is no longer a metal. The other possibility is someone has decided to do some so-called research on nanoparticles, which are, of course, used in the mRNA vaccines, and has put two and two together and ended up with 42. Now, nanomedicine just happens to be one of my research areas, and I share the field with thousands of other scientists. Now, there's lots of different types of nanoparticles that are being explored, but one particular area that is being looked at is magnetic nanoparticles. And amongst the areas they're being explored for is, imaging and also cancer treatment. So what I'm wondering is if someone has come across a paper about these specific nanoparticles and falsely assumed all nanoparticles are magnetic. It's possible. I mean, of course, another explanation is that someone just made it all up. Anyway, that's it for me, so stay safe, everyone.
Good, can't beat a scientific approach. And of course, Susan is a specialist in nanomedicine. Now, I'll have to ask her what that means one day. We'll maybe do a talk on that. Kappa variant, can't remember which one that was now. Someone will have to remind me on that one. 94 cases, absolutely fantastic. But if it had got to hundreds and then thousands, and then it would have been thousands and tens of thousands. And basically, Australia's been saved again by their very rigorous policies. Now, the long-running saga of me writing to my MP about the intramuscular injections and the possibility of inadvertent intravenous administration of vaccine. Very remote. But I've got a letter here back from the man himself. So this is from Nadim Sahawi, the vaccine minister himself. So it's actually got to the top eventually. So I'll just read you a couple of interesting bits from it. Medicines Healthcare Regulatory Authority has issued updated guidance for healthcare professionals on how to minimise risk and further advise on symptoms for recipients to be aware of 4 or more days after vaccination. As a precautionary measure, anyone who has symptoms is advised to seek prompt medical advice. These symptoms include new onset of severe... I could actually show you this. Where are we? Yeah, a new onset of severe or persistent headache, blurred vision, confusion or seizures. Developing shortness of breath, chest pain, leg swelling or persistent abdominal pain, and unusual skin bruising or pinpoint round spots beyond the injection site, which would be blood leaking into the tissues. So the rest of the letter is things that we already know, of course, but then it does address the particular point And it gives me a website to look at there. Then he says this, from the reports of major thrombosis with concurrent thrombocytopenia, we have not been able to identify any evidence of association with errors in administration in UK cases. Now, that sounds good, but of course, if someone had been given the vaccine into a blood vessel by mistake, the administrator would never know that. There was no way to record that. They would stick it in and squirt it in, and that they wouldn't know where it got. If it had gone into a vessel, they wouldn't know. So I'm not sure that's a valid point there particularly. The very rare clotting condition reported following an administration of the University of Oxford AstraZeneca COVID-19 vaccine is thought to be due to an immunological mechanism rather than the way in which the vaccine is given. Okay, so that does make sense. But I still think giving it by inadvertent intravascular injection, because you stick the needle in and don't aspirate, will increase the risk of that. Based on recommendations in Denmark and based on what seems to make sense to me, but they don't seem to be agreeing with me. Guidance published by Public Health England, PHE, states, and then looks a direct quote from this: there is no need to pull back on the plunger, aspirate before the plunger is depressed to release the vaccine into the muscle because there are no large blood vessels at the recommended injection sites. Full copy of the guidelines. Well, I agree. In the vast majority of people, there is no blood vessels in the deltoid muscle, very few. But we have anatomical variations between individuals. And because these side effects are only occurring in something like 1 in 100,000 cases, then if that would be enough to explain it. So I still think, just for the case of sticking the needle in, aspirating before you inject, as we saw that nurse doing in Thailand, for example, a few days ago, it would be, why would you not want to do that? And also, if we think about the possible inflammatory conditions that may be occurring after the messenger RNA vaccines, again, if the injection was given intravenously, the vaccine, say, went to, the myocardium and the heart, that was taken up by the myocardial cells. The vaccine causes the cells to produce the spike protein. The spike protein on the myocardial cells would be recognised by the immune system. They would presumably attack those, and that would cause a degree of inflammation, which could be a cause of myocarditis, if that turns out to be a genuine phenomena. So just like you get a sore arm in the injection site because of this inflammatory reaction in the muscles, could you not get that somewhere else if it was given inadvertently? So basically, this letter from Nadim Zahawi, and we can assume he's well advised, I think, basically the crux of it here says that it's not possible to give an intravascular injection when you're using the deltoid. But I think 1 in every few thousand it might be. So I still think that is an issue that governments around the world should consider with a view to putting that in their recommendations. But got to the minister responsible. Hard to think of what else we can do, really. But that was the official response. And we agree it's probably almost, well, we know it's caused by an immunological reaction, but is the reaction more likely if there was an intravascular component to the vaccine? We might never find out, because that's the official response. So I appreciate Nadim Zahawi replying. It's good of him. It took a while, but anyway, maybe just asking the question stimulated a few people to think about it. And anything that encourages safe practice is, of course, good. Thank you, Susan. Thank you, Julie. And thank you for watching.